So good afternoon, good evening, good morning, and most of you expect it is good afternoon, but I just want to welcome you all to this very important talk we're giving this afternoon, which is a joint online seminar by our Department of English and Communication, but organised by the International Research Centre for the Advancement of Health Communication. And the speaker today is Dr. Wendy Wong, and I've known Wendy for 6 years. She came to a talk that another colleague of mine, Dr. David Hewitt, was giving when he was in Hong Kong, and we connected through that and have worked together on and off for the 6 years. Wendy was one of the first speakers at the first conference that I organised for our centre. And it's also fitting, therefore, that Wendy should be the last speaker before I sign off as director, because today is the last day that I'm going to be formally the director of this centre, and I'm going to be handing over to Dr. Stefano Occupinti, who's here, and the centre will be in very good hands. So I think that's rather nice that it's timed this way. So let me just say something about Wendy before I allow her to give her talk. She's director of the Dr. Wendy Wong Clinic, and her expertise is colorectal cancer and very much in the area of Chinese traditional medicine. And I think it's important that we get to learn a little bit more about this. She is also honorary professor of the National Institute of Disease Prevention and Body Constitution at Beijing University of Chinese Medicine. Her research interests include traditional Chinese medicine, patients' reported outcomes of Chinese body constitution, primary healthcare, randomized clinical trials of integrative medicine, Chinese medicine cancer treatments, and very close to my heart, interdisciplinary communication. So I think Wendy is well versed and has expertise that we will all gain from this afternoon. So Wendy's talk is clinical co-governance of improving integrative cancer care in the private sector. So without any more ado, I'd like to hand over to Dr. Wendy Wong.
Thank you, Benedict. It is my honor to witness the first. I hope this will not be the last one, but we keep the communication still rolling, because I think the topic here today is talking about the emergency and also what I'm working now on. So before I go into details, I give you a big picture why this communication is so important. In the heads of a mom and also practicing for more than 15 years. This, as you can see on the left-hand side, there is a very chubby girl, which I encountered just a few months ago. So this is a 10-year-old girl, which is not the real person, of course. 10-year-old girl with the parents walking. So she is suffering from stage 4 osteosarcoma since the year 2019. So this is a term that you can think about. This is a kind of very, very malignant bone cancer. So the parents already admitted that the oncologist from the children's hospital is overusing the chemotherapy for this this girl, because for fighting the cancer. So they tell me that the girl is with a little bit of impairment of renal function. So as a Chinese medicine practitioner, would you like, or is it able for me to take over of these patients? Because very overwhelming, very depressing status right now. So you can think about, because as you may know that Chinese medicine sometimes may impair some liver function. There's many, just like 7-Eleven, there are more than 10,000 Chinese medicine practitioners in the private market. But they are serving, I could say, why cancer is being a very terrible issue in Hong Kong, because it's already being 30% of the death accounted for cancer. So the Hong Kong government, you can see here, there are more than 42,000 new cases being diagnosed in Hong Kong. So that means there are lots of cancer patients here. So in Hong Kong government, they are predicting more of them are from the colorectal cancer, breast cancer, lung cancer, pancreatic cancer, and also liver cancer as well. So the Hong Kong government do really understand and know there is a very hitting demand in the market. So you can see here, Dr. Tony Go published it in 2018. They found that more than what we call the frontline physician or primary care is the one who catch up your main complaint in the primary market. So 18% of the cancer patient, in fact, will find Chinese medicine practitioner in the market. Only when they really terminal ill, they will go back what we call the tertiary care from the hospital authority. So that's why they can approach more than of that. So even though the Hong Kong government is talking about they are projecting the 2019 for the Hong Kong cancer strategies, however, with this official document, there is no Chinese medicine practitioner in this document at all. Maybe just only a few lines. They are talking about maybe in 2025, when the first Chinese medicine hospital is going to established, they will try to see any pilot study that could able to help the patient. But from this conversation, even though you are layman here, you will find that, for example, the very famous Taiwan, which try to get the Chinese medicine help, or from, for example, they find it patients will go to look for very regimen from the newspaper, or maybe only patients platform, they will transmitting all kinds of 早傳備方. But we are talking about usually the patient who is one of the very signature stars in Hong Kong, who are already nowadays we are encountering from not only the colorectal cancer, but also prostate cancer, or maybe 3 kinds of cancer on one patient. This is those that we are encountering. So that's why date back to 2017. The hospital authority tried to establish what we call the cancer case manager program, try to bridge the communication gap between the cancer patients, the nurse, the surgeon, oncologist, or primary care doctors, or social workers, all along this line. So they are very proud of, for example, 40,000 of breast cancer patients, and also 16,000 of colorectal cancer patients. But as I mentioned, in this program, they do not still have Chinese medicine practitioner in this communication gap. As I mentioned before, this conversation is terrible because when you approach some Chinese medicine practitioner in the private market, who may or may not be knowing what Western medical doctors is talking about. Not to mention the locally, but we have to admit that there is some Western side from other country from the experience. So you can see here, this is a very good journal from the British medical journals. So the European countries have been talking about the EMA, which is a kind of FDA in the Europe countries. From 2009 to 2030, they reviewed more than 57% of the anti-cancer drugs in the market. They are very expensive and incapable to improve the quality of life or improving expectancy. That means there's a new issue talking about is about a financial toxicity in the patient as well. Although there is international insights on the use of the complementary and alternative medicine, such as the National Comprehensive Cancer Network, the NCCN, they have published what we call the clinical guidelines. 5 out of 11 of them already mentioning acupuncture is very useful for their survivalship in cancer patients, in palliative care, anti-emesis, and cancer-related fatigue, and also pain as well. However, the WHO also stand up for this kind of change, if patients, we are talking about the traditional medicine strategies from day back to 2002 to 2005, and even projecting this the same thing until 2023. I think these days we are suffering still just the wake up of the COVID-19. Therefore, that means not only Hong Kong, but globally, there is a need of integrated medicine in the cancer care as well. But are the Chinese medicine practitioner really ready for this change? I need to admit that they may be no or maybe yes. I think the conversation is still rolling out. As I mentioned, for cancer care, there are more than 10,000 of Chinese medicine practitioners being practicing in Hong Kong. But how about cancer for the Western side? So there are already general physicians for 12,000 of them. Radiologists is still date back to 500 something. So oncologists, there are 150. But as I mentioned, there are more than 10,000 Chinese medicine practitioners. We always play a joke, like Chinese medicine is just like 7-Eleven. So you can always find someone around you. So they are graduated from Beijing, Guangzhou, Shanghai, or maybe different areas in China. Or even though maybe you cannot differentiate from what we call the registered Chinese medicine practitioner, who is trained formally in the university in Hong Kong or China, or maybe 2,600 of them, they are what they call the listed Chinese medicine practitioner, who are what we call the historical master type of the Chinese medicine practitioner in the market. So as a layman of you, this is already very headache for all of us. So in China, I think we need to admit it a very universal truth, because in China, by law, they do not have a very adequate healthcare professional in the China healthcare system. Therefore, Chinese medicine practitioner in China, in a hospital setting, they could prescribe not only Chinese medicine, but also Western medication and doing surgery on the lecture theater of the operation room. So you can perceive that when they registered in Hong Kong, they are Chinese medicine practitioner, but they are in mindset already swapping both sides. However, in Hong Kong, it is really very not realistic for us if you allow Chinese medicine practitioner like me to prescribe any Western medication for my patients. So you can see that's why we need to share the insights from both sides. So as I already mentioned about the cancer scenario in Hong Kong, let's talk about what the Hong Kong government is going to embark on. So for cancer care, as I mentioned, in 2014, they have already in the Hong Kong government address policy tried to establish the first Chinese medicine hospital in the Tseung Kwan O. So they have the pilot program already date back to 2014 and already bridging in to until now in 2021 for cancer palliative care. So it is just recently being published in the Hong Kong government. So the cancer palliative care in inpatient for 7 years of the hard working, they have served 697 cancer palliative care of the patients. So this is what they are looking for, a protocol type of the service, how they could do the work as well. But as I mentioned, more than 70% of the Chinese medicine practitioner, in fact, they are practicing in the private market. It's not in the public. So that's why I think my private practice right now in this conversation could give you some insights. So it's a kind of triangular conversation that I've shared 5 years ago. And this conversation did not change very much. So from the oncologists, they would not allow Chinese medicine during the chemo or the radiotherapy. So Chinese medicine is only for palliative. So there's no patient referral mechanism or the platform under the Hong Kong laws. So however, this endangers some what we call the herb-drug interaction because of the safety of the herbs, and also sometimes the compliance to the conventional medicine. The patient may pass over the golden period of the treatment. However, from the patient's point of view, this may be their last resort in parallel. So in patient is the one who are the anchor seeking their own Chinese medicine, and also in parallel with the Western medical doctors. It may be lying on the public sector or maybe even though the private sector. But for Chinese medicine practitioner who think that, oh, I am always effective. So you don't know whether bear in mind the story that the patient that I encounter in the private sector who may be catch up or pick up by someone from the 7-Eleven Chinese medicine practitioner who claimed to be effective. So think about it. This is the beloved family member who is suffering from chemotherapy, who are dying. So, but if we are not communicating, I think this is just like a kind of all lost situation there. So that's why this is a heart-burning issue that I want to share, to also give you some insights from my research, my clinical experience, but also what is the practical will if we could communicate. So the research and also what I'm doing is to review the process of care to identify the communication gap, what is the barrier factors and enabling factors from the oncologists, from the family physicians or general practitioner, and also Chinese medicine practitioner, and also the patients. And I would like to project to evaluate the process of care from the above factors to facilitate patient-centered care in the private sectors for public and also private partnerships. So I hope that my sharing will be insightful for you to inspire your research and also to help the communication between different key stakeholders. So from the healthcare point of view, from healthcare management, we're not only doing qualitative study, but can we make some changes? So if this is the heart-burning issue to do something. So the first, we need to create the idea for innovation to enabling healthcare innovation from different parties. So we will create a climate of change. And the second phase, we will engage and enable the organization to implement such changes. And for phase B, it will embed and sustain changes in our healthcare systems as well. So in the research, I have interviewed some my oncologist colleagues, and also from public and private sectors, and also some of my nurses. And also you can see that we found patients, oncologists, and also Chinese medicine practitioners in different areas. And this is the areas that I have identified. There's first come, first serve is about safety. So therefore, they found that it is a lack of herb-drug interaction database. And also they do not have a lack of sharing data from the patients, oncologists, and Chinese medicine practitioner, either from the public or private. And also about the prescriptions rights is about the topic that I have touched on, is about the clinical co-governance. And also they are encountering language barrier. For example, whether we are talking about the medical context in Chinese or English. And also there are some concern about the quality of Chinese medicine herbs they are using. And also the last one is about the financial toxicity of the patients. So how can we encounter this current process of care in our private sectors? First of all, how can we make the change? The first one is about how can we handle the lack of herb-drug interaction database. So what we can make some changes for this one. So as I mentioned about safety first, we are very delightful because we have the School of Pharmacy from the Chinese University of Hong Kong. They have the largest, because we are talking about the private sectors, even though patients in the hospital authority, they do not have the widest coverage of the anti-cancer drugs because they are what we call the subsidized scheme program. Therefore, only those covered from the hospital authority will be have maybe 70% of them. But the widest one is in the private sectors, which is the last 30% of them, which is the latest one that they are doing in the private market. So therefore, the private market have the widest coverage of the anti-cancer medication in the market. However, for the Chinese medicine, that's why we need the Chinese University of Hong Kong, which is have the highest database in the Chinese herbs in China as well. So this is a free database. The POBOX, you can see here, when you log into this database, you can search any kind of Chinese medicine, but also latest private market database as well. So in my practice right now, and also I share with some of my Chinese medicine practitioner who is focused in cancer care. So you can see here in the database is very useful because, for example, in breast cancer patient, tamoxifen is one of the commonly used hormones replacement therapy that try to protect patients from the breast cancer relapse. Okay, so therefore, this database allows the what we call the pharmacodynamics and also pharmacokinetics, how it will interact with potential herbs that we used in our clinical practice. So you can see here, when I enter it, just like Google, but this is a first specialized one. So when I input tamoxifen and I search herbs, and it will showcase, oh, we have found that there are 10 herbs that has potential herb-drug interaction with this tamoxifen, which is commonly used. However, I found that there is some dongguai, which is usually used in breast cancer patient. There is herb-drug interaction, found that that's just only one of them. That is endometrial cancer. That means they are not really readily, just only when I have a summary of that. So there's two kinds. That means for the first level, we have found that there is some herb-drug interaction. But in clinical practice, that is another level, what we call in clinical practice. This is not very essential. They are just impacting for aged 20 to 79 years old patient with endometrial cancer patient. That means when I prescribe some herbs for tamoxifen patient in breast cancer patient, I can more than safe to prescribe dongguai to my breast cancer patient. So you can see safety is the safety first. And when I'm presenting this, what we call checking database actions, we are still not only protecting my cancer patient, but also protecting myself and also my colleagues that refer patients to me. So I think this is another database that they are being used in the UK or Australia, which is free of charge. But you can see that they are using what we call the out of the list 1 and list 2, for example, Chinese herbs that is outside our Hong Kong practice in regulating our practice as well. That means in China, they are using 7,000 of Chinese herbs. In Hong Kong, we are just using 700, but apart from 7,000, Australia, UK, or United States, they are more than 7,000, which is already out of scope. So therefore, we are using different database to make sure, because patient is flying over, not only from local demand, but also we are very approachable for different kinds of supplements. We need to check the database. So this is a kind of good practice that we are using right now. So even though I'm talking about not only Google it, but sometimes I will still check the database as a kind of best practice that we are governing ourselves. So the second enabling factors is to whether we could able to share the data on the same page with public-private and also in our patients as well. So you can see here, with the support of the in private sectors, my oncologists or maybe family medicine doctors are able to help me to access to the electronic health records from the government. I think I need to share with you from the currently, the electronic health records is only accessible for myself in Chinese medicine in the hospital authority. However, patient consulting me, I am not able to really reach a patient with their PET CT or maybe the blood record. Because as I mentioned, patients approaching me have, as I mentioned, he or she have the liver or kidney failure as well. But I don't know what is exactly the point, how is the statistic and how exactly the patient is being impaired by the chemotherapy. But you can see here in the private sectors, my oncologist helped me with the medical record. This is the medical record in the oncologist helped me to embark on. And this is the Chinese clinical notes that I wrote in Chinese, but we are writing on the same language in the Western medical side. So therefore, my oncologist is very helpful for me to see along the patient, the girl, with the PET CT and also the complete blood count about the liver function and also kidney function here. So you can see that's why in private sectors, even though we are working different center, we try to bridge the language, not only Chinese and English, but also medical context based on the Western medical side. So we break the language barrier, and then we go to the key point. It's about the clinical co-governance, whether we could help patients safely on a very good scenario of we are talking about. So bear in mind, the girl that I shown just in the beginning of the data in the story. So this is the girl that finally I found her blood report. So you can see here, the girl, when she visited me, the platelet here is only 13. So which imply you can think about this girl is dying. So with the chemotherapy, I talked to the, that's the reason why when I able to reach this blood report, the family member also tried to get me connected with the children hospital for the senior consultant. We have talked about the platelet is very poor. And then after 1 week of the treatment, you can see here, for normal patient is 200 to 400 something. But after 1 week of the treatment, the girl survived and the blood platelet from 13 to 110. So the reality here, not only about the blood issue, but also we are talking about the creatinine, which is the liver kidney function. In fact, originally the mother told me her girl is only very poor, but it is quite good. You can see it is still under normal range. But however, the liver function is here. Can you see here? The girl is already not so good. But after the chemotherapy, the liver function tried to drop a lot. So you can see here the communication is quite mismatched, as when patients come to me with the statistic talking about the kidney function is poor. But when we talk about the blood report, it is not that reality. So we are trying to talk to the senior consultant, talking about they are stopping the chemotherapy. We try to use Chinese medicine to help the patient first. And then the clinical governance that switch from this point of time. But when I hand over back the patient back to the Chinese, the children hospital, the oncologists again feel much more safer because they know that the blood report of the girl is much better. And then they continue the chemotherapy again. So that is why the sweeping of clinical co-governance really happens here. So that's why we have bridging between bridging the language barrier, and also this is the key point on the prescription rights and also the clinical governance when patients are jumping from public private, but also if we are talking about I'm waiting for the electronic health record from the Hong Kong government or the public hospital, the patient need to wait for 3 months time to review the blood report. But you can see this is the heart-burning issue when we are saving lives. So we can see here when we are sharing data on the same page, it may be able for practitioner like us to save life as well. So not only about how we use the herb-drug interaction database, for the oncologists we talk about, we have been using the guidelines to tell them that we are using helping in different stages. For example, we want patients to do the surgery as soon as possible. And when patient really have metastasized in this mid stage or maybe the final stage, we would like to help patient to increase the surgical recovery, decrease the rates of complication, recurrence, or metastasis. And also we would like to really intervene earlier to decrease the adverse effect of the conventional therapy, for example, neurotoxicity, cancer cachexia, and the use of steroid. As I mentioned, patient will have a very poor bone marrow suppression. That's why the blood count try to drop to a very lethal stages. And we try to help to patients when they are really in that kind. So we would try to increase the compliance to the chemotherapy, improving health-related quality of life, and increase the 5-year survival for late-stage cancer patients. Not only in Western medical communication, but we try hard to also share the wisdom from China experience when they are using Chinese medicine as well. So you can see here from the early stage of the cancer, and also what we call the preventive stages to the early stage and middle and the late stage of the cancer. They have very regular update in clinical practice of guidelines when in Chinese medicine, in oncology as well. So when we have presenting this kind of guidelines in our practice, the communication is much better when we communicate with the oncologists and pharmacists and also the surgeon as well. So how about the patients? As I mentioned, it is not 7-Eleven when we are talking about cancer patient. It's not about claiming that 100% we can guarantee the resolve of the scenario when we are talking about the girls. But the patient, we need them to be expecting that they are facing death in this kind of clinical scenario. That's why the patient-centered communication framework that had embarked on the NCCN, we are trying to be much more professional by the 6th domain, which is the first one is about responding to emotions of the patient, exchanging information, enabling patient self-management, managing the uncertainty, and also fostering healing relationship, and also making decisions during the conversations. So I'm grateful for 2019. There is the first what we call the professional diploma program in holistic cancer care for Chinese medicine practitioner have been embarked on the Chinese University of Hong Kong for the Hong Kong Institute of Integrative Medicine. So that means they are nurturing 50 Chinese medicine practitioner with this kind of accreditation that could be reached by the layman in the market. That means in the private market or the oncologists or my colleagues as well. So that means there is a kind of education, innovation, and also a pilot model for integrative professional development pathway. For example, after the postgraduate training, they need to have a panel for not only Western medicine doctors, but also Chinese medicine expertise to have what we call the Part 1 and also Part 2 examination to revamp the whole curriculum for cancer care to try to embark on the, for example, some Chinese medicine practitioner fresh graduates, they need to really complete the postgraduate training from both the Chinese side and also Western medical side in order to prepare the seedling for the inpatient training when 2 years later on, the Chinese medicine hospital is trying to establish as well. So maybe some practitioners do not want to be inpatient training. They could still in the market being able to be reached by the patients as well. So this is the model that we are trying to have some kind of educational innovation as well. So this is a kind of multidisciplinary collaborative model. As I mentioned, the model try to help patient with a very good model of care to really help the Chinese medicine practitioner to really the puzzle can be embarked on this kind of communication to help the patients, but also caregivers as well. I'm not sure whether you have been noticed when patients are really diagnosed of cancer, not only themselves, but the caregivers try hard to support the cancer patient with very kind of long-term suffering with this 7 to 8 years of survival. So I think this is a very essential part when we help each other to with this journey. So I'm quite blessed because this model started in 2020. I start from 200 patients, I'm sorry. But now within 2 years, my patients loads in under this center is already reaching 1,500. And the attendance is quite overwhelming. Most of them is what we call it already roll into 42,600. It's already more than the in the inpatient from the hospital authority. So you can imagine, that's why I have to acknowledge the Chinese University of Hong Kong. And also I'm working with another cancer group, which is HIL, and also my colleagues and also the Cancer Information Net, because they are try hard to provide evidence-based practice from the market to help the patient to identify good practice and also best practice, and also Chinese medicine practitioner who are able to communicate with their primary care doctors and oncologists with the public-private partnerships as well. So how about the quality of the Chinese medicine herbs, and also talk about the financial toxicity from the patients as well, how we could handle this? I think we need to understand patients are very capable to reach of any kind of Chinese medicine. So there has been a top medical journal talking about many patients will have drug-induced liver injury. And the top one is talking about traditional Chinese medicine or herbals or dietary supplement that they can get from the market. Either they are prescribing or maybe they are buying from the internet. We got IG nowadays and also Facebook. And even though my patient is giving me a 10 bottles of supplement that they can get from the not only the local market, but maybe from Australia, from United States, whether they could take or not. But the third one is talk about anti-cancer drugs from the medication, also still able to do that. But how about a practitioner that if I'm talking about the context is so dangerous, so is it the real case in locally? So when we reviewed that from the Prince of Wales Hospital, they have for over the 8 months, very interesting. When they reviewed the adverse drug reaction, there are only 0.5 of them related to herbs locally. Okay, so some herbs are what we call those from the United States herbs, or maybe westernized herbs from the health supplements imported from there. But however, when we talk about Chinese herb under the ordinance of Chinese medicine, which is called by the list 1 and list 2, there are only 3 of them really related to what we call the Chinese medicine prescribed the Chinese herbs. That means more than 4.4% is related to Western drugs. That means Chinese medicine practitioners who are well trained nowadays is much more professional, and the incidence of drug-related liver injury is really rare in local case. So how about when we talk to patients, that means the financial toxicity. So we need to be very carefully to talk about this because we need to responding to emotions of our patient in reality. For example, when patients need to really use Chinese medicine to intervene, should patient go for the operation, whether they should use Chinese medicine before the chemotherapy or after the chemotherapy, what they need to expect from the Chinese medicine. Are there any side effects as well? So I think this is very important. So therefore, the safety first, the herb-drug interaction database really come along. So for financial toxicity, it's all about consultation. So in private market, the range is really large. So the Chinese medicine practitioner, the financial consultation fee may range from 180 to 1,000. So for the herbs, usually for each day is about 100 to 300 a day. So you can take into account if you take into 28 days for consecutive for 5 years of survival. That means the range will be $3,000 to $9,000 a month. That means for Western Chinese medicine, it takes you $178,000 to $564,000. So in case maybe with this dollar signs already very overwhelming, patient may ask you, maybe he or she do not want to do any Chinese medicine anymore, but when they should face the death. So is the Chinese medicine practitioner capable to translate this kind of things during their clinical practice? So the second domain is about how we communicate with our patient. We need to exchange information, what food to eat, and food avoidance is one of the major issues in cancer patients because more than 60% of them, they have a tendency of food avoidance. That means they will have a consecutive 2.2 kilograms of weight decrease that will endanger themselves, which is a red flag signs that they should not avoid eating. So this is why Chinese medicine practitioners nowadays try to avoid that as well. And we need to analyze, as I mentioned, there are any kind of supplements all over the world. So we need to explain with them with different kind of categories of the health supplement to read the food labels and also ingredient labels as well. So that's why we always welcome patients to exchange the information when they are taking any kind of supplements. So as I mentioned, food avoidance, more than 40 to 60% of the cancer patient will have a tendency of food avoidance that lead to what we call the cancer cachexia, which is more than 2.2 kilograms of the weight loss in each week. So this is a terrible issue. And also we need to go over with the evidence that we have in the guidelines about the food avoidance for the cancer patient with the global guideline from the American Institute of Cancer Research, which is the World Cancer Research Fund, and whether a patient is able to have some kind of what we call the soup cooking habits in their daily life, for example, dong quai, or whether they could use ginseng. It depends on the herb-drug interaction database again. You always try to check with their chemotherapy and also target therapy, which is already for the last 10 years, all the anti-cancer drugs already renovated and it's totally different from the old days. That's why we always go back to the database and to try to help patients to translate all the informations. And also patients are very skeptics, and also when they really encounter doctors start talking about, oh, your condition changed. maybe in positive way or negative way. So how can we manage our patients when there is some kind of changes or uncertainties, especially when cancer biomarkers increase or decrease? We always go back to the medical reports that they have. We will not guess by blinding our eyes. So therefore, and we will stick to the clinical guidelines that we are talking about. So you can see this ovarian cancer patient from one of my colleagues. Her patients have what we call the ovarian cancer biomarker increasing in gradually. However, the PET-CT or the MRI is pretty stable. So we need to talk to the patient that he or she, the treatment did not change because in fact, biomarker is only one of the phases of the treatment along, because we need to understand in medical terms, when the ovaries got inflammation, the patient with the cancer biomarker is also rising. But with imaging, we confirmed that this is not very essential. So the patient is much more satisfied and amplified on what he or she will be fear of. We also enable patients with self-management, with acupoints about when they're handling their fatigue, their pain, and also maybe someday point of time, they have abdominal distension about the edema, pleural effusion or ascites, because this is a sign of closing maybe to what we call the disease progression. I think we need to be very mindful and also be true to the patient. We have to accept that one day when Chinese medicine is not able to hold the disease progression anymore, we need to admit that and ask the patient and also the family member to face the reality. But also we try to help with the bowel movement and also the quality as well. So we fostering the healing relationship with the patient, help them to stay positive, because we don't know whether the patient where or when there is one day of disease progression, and also not only focus on the disease, but also focus on the value of their life and the definition and what is the meaning of life. And also we help them to do some exercise or mindfulness or qigong or even those yoga as well. So I think making decision is very difficult, but we usually, as a Chinese medicine practitioner, we still help them. Will they really want to opt for the Chinese medicine if there is some kinds of what we call the financial affordable, whether he or she or not, maybe they would not like to opt for, whether they would like to take Chinese medicine, and whether we would like to update the guidelines with the patient to tell them what is the effectiveness of the treatment as well. So financial toxicity is one of the new area that we touch on because of the old insurance coverage. They are usually using get-set rate, which is over, or usually patient need to pay over that, I mean, out of their pocket, which is not being subsidized by the public government, or even though they find that their insurance cannot able to cover all of them. So be mindful. I think most of the academics here are quite young, but even though if you have insurance, go back to your beloved family members, whether they have updated their package insurance, that because the latest one, I found out they are much more comprehensive for the coverage of Chinese medicine, or maybe even though art therapy or yoga therapy, but not only covering the patients themselves, but the family member being involved is also being covered. So I highly recommend, because chemotherapy, target therapy is very expensive. So take a long look at the contract and the terms and conditions when you're overcoming this issue. So this is the newspaper talking about Professor Tony Mok, which is the giants in the lung cancer. The first line of treatment is target therapy, but the survival is very good. But each month they are spending in the private markets is $50,000. So which is already another very sad story, because patient not talking about a very privileged family, but primarily a household. They only when they are talking about spending $4,000 a month for the anti-cancer drugs, is already very, very expensive. So that's why we try hard to make the scenarios much more simple, but also whether we could help with the survival. So what I'm doing right now in the private market, I'm very thankful for the Chinese U. When I left in the university, we're still doing interprofessional training, cancer care. That's why I published a book with collaboration with not only the oncologists, but the pharmacists as well. We bring along cross-disciplinary collaboration in publishing a book, evidence-based for cancer patients, whether in different stages we could support with evidence how we could help in the enabling as well. So to make the summary short, because we know that in the old days, the active treatment usually with surgery or chemotherapy in Hong Kong, when the oncologist always ask the patient not to try to seek Chinese medicine after the active treatment. Usually in average, it is 3 to 8 weeks before they pass to palliative care, which is closing death. So with more treatment available, now I'll talk about not only surgery, chemotherapy, radiotherapy, but also target and immunotherapy. So the stretching of the end of stage life is much more stretched, maybe more lesser time. But when you hand over the cancer patient to us with a very late stage, like in the inpatient, in the Hong Kong government, in the hospital authority, it may be too late for patient to be used by Chinese medicine. So in Chinese terms, sometimes we are talking about good death or poor death. In Hong Kong, we are quite sad to say that we are only just ranking in the 22nd for the quality of death. So it's quite a kind of sad story, even though Taiwan have a very better and good ranking as the 6th in this scenario. So I think we have discussed about in private sectors. I have showcased how we are using Herbal interaction database to collaborate with my oncologists and also my pharmacists and also patients from the public and private sectors. This showcase about the prescription rights. When we are talking about clinical co-governance, we really need a database in sharing data along with the communications about not yin-yang or 5 elements anymore. We need to be very practical to talk about patients' blood reports and imaging to save lives. And also the language barrier, whether it is Chinese or English or not, it doesn't really matter, but we need to have a good medical record on the medical side to protect both sides. And also the quality of the Chinese herbs that we are using is very important as well. But however, financial toxicity is one of the issues that I'm a very small potatoes here, I'm no one, which is another issue that the private and also the public hospital, I think, for example, the healthcare voucher for the aging population is definitely another issue that we need to ride on. So from the patient point of view, of course, we are now not talking about public-private partnership, but a patient-centered healthcare system we ongoing, because as I mentioned, the context about the global interest in integrated medicine, not only Hong Kong people, but when traditional Chinese medicine try to immigrate from Hong Kong to UK or United States, or maybe Europe, they are talking about the global use of traditional Chinese medicine all over the world. That's why there's engagement when patients loading is very increasing or rising, or maybe in clinical practice, we need to use clinical audit, and also for the blood report from the data. That means the telemedicine and the COVID really illustrate that database in driving this kind of change in health seeking behavior become very crucial for us to know whether we could able to increase the patient satisfaction and also the needs of the medical service as well. So for internal staff or evaluation of the process of care become very important as well. So last but not the least, I think the doctor's patient's relationship. I'm very grateful for the last 2 years. My patient really increased a lot because you can see that the case of the girl, we saved her life. I don't know whether she could sustain, but I think this is the communication we try to help on. And therefore, my presentation comes to an end here, but also thankful to Benedict in giving me a chance to share my passion and also in bringing up this issue, because I think this is very important, and also with the change of the flagship in Chinese medicine hospital in here right now, right here. So I hope that my insights and sharing could give you some insights on that. Thank you.